Dr. Zana, you were quite optimistic about the number of jobs that this digital transformation will create. Is that not a little bit over-optimistic? That many of the functions that you mentioned on the latter slides were perfectly capable of being done by software now, and with the advent of better AI, that will take over from the data analytic roles. So essentially, we will do the jobs that the digital devices and particularly robotics cannot do, and that number of roles will diminish.
Is this on? As said, I unfortunately know very little about the contamination and sterilization services. It probably could be summed up in this morning's talks. But the numbers that I quoted are generally applicable across the entire health and social care workforce. And obviously AI is coming, but it is coming very, very slowly across the health and care services. So you first need all of the digitalization processes to be in place, and they need to be implemented. And whether you can implement AI directly and it'll take over jobs, perhaps it can do, I don't know. It will, but I don't think AI will erase jobs, it will change jobs. It will definitely change most of the roles across the health, across any job category. But the number I quoted, the 1.3 million AI specialists, that's from a UK government document, their own prediction. So that's across the economy, not just in healthcare. So I don't know if this actually answers your question at all. I don't know what the level of digital transformation is within decontamination sterilization services currently. So I don't know whether we're starting from scratch, whether it's kind of already happening in pockets, or whether it's already quite a commonplace thing. So unfortunately, I can't really say more accurately than that. I don't know if you...
No, but if anybody else has got a question, I'm going to ask Sana a question as well. Yeah. Sorry, Sana. I've come from, blackboard and chalk all the way to where we are now. Sometimes I wish I'd just had a blackboard and chalk. Endoscopy itself, yes, we're coming a long way in terms of digital transformation, electronic patient records. A lot of AI in endoscopy now, and some of you guys will be aware of endoscopes with AI capability, telling us when we've missed pathology. But very useful. We've talked a bit about the pill cam and the role you guys have had in developing that. This is probably a really naughty question, actually, but from my perspective, our endoscopy database, all the things we have, all goes up in the cloud now. What happens when digital technology fails? What are our backups? Because, I've had instances where the database, whether it's not gone up to the cloud and where the data's not there, and what are our fail-safes for that, which ultimately is going to happen, isn't it? We're going to have it. But.
Well, I would say the weakest link often in digital services is the human, but also it is also the backup. So digital should be seen as the kind of assistant and the helper, especially AI. AI is only as good as you make it. So rubbish in, rubbish out. So that's why, especially in health and social care context and any context, you need to be very, very careful with what kind of data you put in, and that the data is verified by humans and it is accurate. So if you input rubbish data, it will give you rubbish outcomes as well. But with AI, it is always the assistant. I would say that it's almost like, there's a saying about fire that it is, this is maybe a Finnish saying, I don't know if it translates very well into English, but it's a very good servant, but very bad master. And I would say it's the same thing with AI, that it's a very good servant, but very bad master. You always have to be in the driving seat with AI. So it's not like it's going to be doing everything for you. You have to be able to check that it's doing them things correctly.
Thank you, Zana. A typical example I can think is, you mentioned predictive, and I'm not putting you on the spot because that would be unfair. You talk about predictive maintenance, and you think of a machine with a pump failing, a pump squealing, cavitating, etc. Would they be able to? I'm not expecting you to answer this, but how they would pick. I'd welcome some of my colleagues in the audience to answer this. Really, how would they pick up on a pump that is probably squealing, cavitating for a variety of reasons, is not performing? as I go back earlier to an engineer looking at a machine. You know, I think we can never get away from that. But I take on board what you say. Anybody in the audience like to talk on that particular example? Do you think we're going to go away from engineer visits?
I think, John, we can move away, certainly, from technicians when you go there, finding your endoscopy technicians taking the front off the machine and has got their own little toolkit there to twiddle and turn alarms off. It did happen. It used to happen.
Have a go, heroes
Have a
again.
go, heroes, yeah.
The gentleman at the back.
Yeah, I was just going to say that I've come across and talked to individuals about this, and I think, like the lady mentioned earlier, it's not to replace the human, but from the pump is that the data that's put in across the country of an average time of that life expectancy of the pump is so many years. That then gives the ability to be able to work out how old your pump is and when that potentially is going to fail. So in a service, we don't want anything to fail, do we? We want which impacts on patients. We want, continuity. So replacing a pump prior to the date that it's given that it may fail, based on data across the world or the country, I think it's excellent, to be fair. Yeah, that's all really, just a comment on it.
Yeah, no, that's great. Gentlemen.
I think there is a danger with a lot of data information that the data takes over. So using your example with, as an engineer myself, using your example with things like pumps and stuff, it's with then a danger of the manufacturers locking everything down to the point that, a little bit like cars now, you can't fix them without going to a garage. And then how long are we waiting for an engineer to attend to rectify this failed reprocessor washer? That's then out of cycle. How much impact is that having on the service? Rather than it's nuts and bolts and screws, it's broken, we've got another one, we unbolt it, we bolt it on. It works again. You can use the data to influence, right, this pump is now done this many hours of cycle, the temperature's rising, the current's being, going up gradually, it looks like it's on its way out, we can proactively change it. But where do we get to a point where it's then becomes a sealed system that we can't touch?
No, totally agree. Thank you.
Thank you. That's an interesting example. And I maybe could point to the sort of joint co-design process for services. Then, like, this is if a new device is brought into part of a service that will radically change the way that the service can be delivered, it should be co-designed with everybody involved in that process. That would highlight issues like that. We talked about this morning about the robotic surgery example, where the engineers have developed this fantastic robotic surgeon tool, and Helen told me that it doesn't actually comply with, or didn't comply with, the decontamination processes, and that's a prime example of poor design, where like good design only of these devices only happens when you have everybody who has some kind of stake at using and having this new device as part of the service. So for it to work well, it has to take that kind of things into account.
And I think that doesn't always happen, does it, with decontamination being involved in these things? So I think that's really, really important, yeah.
So what's the consideration for cyber attacks? Although it's not a decontamination world, at the back end of last year, a local manufacturer was brought down for months because of a cyber attack, and they were a multi-million-pound manufacturer that then lost data, staff were sent home, all because of a cyber attack. So where is the consideration in the digital world and going forward with that?
Yeah, that's a very good question as well. And it's, I would go back to saying that when you are designing any kind of system that involves digital, there's kind of cybersecurity considerations where possible should be embedded into these processes. There was I don't know if anyone of you have heard of this massive data breach that happened in Finland with a mental health provider that had online services. 30,000 people's data was stolen. And it was maybe just a poor bad password kind of choice by somebody, and it could be like, again, as I said, often human is the weakest link in these digital systems, because systems, they involve people and things. But I don't know, this is again not probably answering your question, but cybersecurity beginning from the start of the design of the process is important to try and avoid those. I don't know whether these can be entirely avoided altogether. And if, as again, say that the system is designed, if it, yeah, I don't know, there's always a risk associated. Like if it's so risky that it actually risks human lives, maybe you need to do it manually. I don't know, that it is also an option. Certain things can be made more efficient with digital, but if there are certain things that are too risky, then that's the decision to be made with the design process.
Do you think, bearing in mind COVID was a prime example with the PPE shortages, what we're seeing in the world today, the example you give, I'm totally with you on that, but do you think us as organisations, we have enough contingencies, so when these type of things happen, have we gone too reliant on, software-based systems, and we've got no resilience to deal with things when they go wrong to that level? Well, what's your thoughts?
That is my concern. I think seeing the Jaguar Land Rover issue, obviously they relied heavily on their database and their network, and it brought them to their knees, and also manufacturers that supported them. And it is my big concern with data that actually if there is a cyber attack if we had a cyber attack now, it's actually then how would we be able to do what we need to do to get the equipment out. Now, as a decontamination facility, we do have manual systems and manual traceability that we can go back to. But it's obviously looking at the wider thing, and I think I'm nervous about the reliance on data and data technology, and I think it's great, and I think it has its place, but I'm concerned that we're becoming overly reliant on it, and actually what's our backup plan when it goes wrong? Because it can, and there's always somebody out there trying to bring you down for whatever reason, just because they're bored, teenagers or bigger.
Yeah. Would you ever test, I get what you say, and you talk about your contingency plan. Do you ever test that contingency plan?
We don't as much as I think we should, because I suppose it doesn't get used very often. But it is something we do look at in terms of testing it to make sure we can use it if we need to.
My question's to you, John. Talking about the development of standards and the implementation of, the new HTMs coming forward, do you think there should be more engagement with the manufacturers of the decontamination equipment in the development of these standards? And my second question is around the validation process. As I do agree and totally accept the rationale behind the additional testing that needs to be done, is there any consideration to the commercial impact of those validation tests that the hospitals and the trusts are having to pick up on?
No, I think you make a great point, Keith. I think obviously the consultation process for these HTMs is not my, that's outside of my control. You guys are part of IDSC, IHEAM, all the relevant institutes. So I suppose, as individuals and as commercial partners, you should make sure that you are aware of the HTM revisions and you comment accordingly, from a commercial entity perspective. Totally agree on that. I think the commercial, I think you're totally right. I think probably we as a group, because I think, I mentioned perhaps the ACT, the Bowie-Dick tests, etc. And I know Brian's looking at me with lasers. I'm not saying we should do without those, but perhaps we should look at putting resources into testing areas of greatest risk. I think, the cabinets is a prime example that I mentioned. And it's nobody's fault, it's just cabinets came in after, they're down the evolution chain from the sterilizer, the washer disinfector, the endoscope washer disinfector. They are, they come along after. So, yeah, perhaps we should put a little bit more resource into that level of testing and perhaps, take other testing to a slightly lesser level. I'm with you on that, and I think, the point you make is relevant because, I work within the NHS and we are constantly, people are saying this is costing a fortune, you know. But tests must be relevant and where the greatest risks are. So I'm with you on that.
Yeah, just to sort of back you up on there, John. I mean, when it comes down to AEDs commenting then on certain standards, I think all we're asking for is for equipment to be tested to the standards that declarations are being made that they have been manufactured to. So I think from our point, like we say, and we're always putting the patient first. So if we can enhance protocols and we see gaps in the market maybe that we need to be looking at, then I think the documents that we do put out from an IHEAN basis is consensus driven, is done by the Decontamination Technical Platform, and then obviously we agree, comment that, you know, alternatively within. And I just think that what we are trying to achieve and working with the manufacturers, I mean, as ADs, we all have good working relationships with the manufacturers, and we're all there for one thing, which is a safe patient outcome, whether it's a scope or a medical device.
Helen, any thoughts on that?
No, I've got nothing else to add on that. I think it's just really important that we, you know, it's you guys that drive the decisions that we make, in fairness. You know, what we look at is, which I want to see more of in those, is about the processes and the pathways. And, you know, I want to see those in those, bit more of those in the standards, although we have the BSG standards that we use to cover that and which are widely used by people, as I say, in the swampy lowlands, the people doing the work. But I think in those standards, it's got to be a balance of both.
Hi, morning all. I'm from King's College Hospital. John, you just touched on the question regarding the airflows for the compressors. Do we have a standard for that one, or we have to rely on the manufacturers?
Sorry, did you say air quality?
Yeah.
Well, the manufacturers should give you that guidance, but there's also pharmacopoeia standards for air quality and medical gas requirements, which is what we would use, basically. Revert back to the HTMs for medical air.
Okay, thank you.
Okay.